having me today. It's a great pleasure for me to be here. So what I'm going to talk about preventive biomechanics, and more specifically, current neuromotor concepts and what's my current passion, which is to reduce both primary and secondary ACL injuries in young athletes. One of the reasons this is such a passion for me is these are my two academic daughters. As you can see, they're identical twins, Carmen and Katie. They both suffered ACL injuries, primary ACL injuries, during one of our prospective cohort studies when I was in Cincinnati. And then not soon after that, Carmen had a second ACL tear. And then several years later, Katie also had a second ACL tear. And what you can see here, they're at age 30 receiving their PT PhDs and MD PhDs, and they've already had cartilage resurfacing procedures in their knees between the ages of 17 and 30. So what we use is this technique or approach we call preventive biomechanics, and we actually study several areas: systemic exercise, neurological issues like concussion, cardiovascular issues like cardiomyopathy, genetic issues, some of which I'm going to show you today, including Carmen and Katie's pedigree, but also musculoskeletal, like this problem of ACL injuries that leads to cartilage problems. So what are the long-term impacts of ACL injury? This was a recent study in the American Journal of Cardiology, which, as expected, former NFL players who had an ACL rupture had a twofold increase in musculoskeletal morbidities and arthritis, knee joint replacement, and a more than 50% increase risk of myocardial infarction compared to those without ACL tears. So unexpectedly, there's even an increase, a 50% increased risk in cardiovascular disease. And we're following up these studies with larger data sets. So in order to reduce the risk of these injuries, what we need to do first is look at the ACL injury mechanics. So this is a common injury, especially in cutting, pivoting, landing sports. Females are predisposed. Per exposure, they have higher risk than males. 70 to 80% of these are non-contact injuries, which gives us a great opportunity because if they're non-contact, they're internal to the body and we can alter that risk. And they occur quickly, usually within 30, 40 milliseconds of rapid deceleration and landing. And importantly, I'm going to show you a lot of data that it takes multiplanar torques applied to the knee joint all simultaneously to rupture the ligament. This is Rebecca Lobo tearing her ACL in the WNBA. At that time, she was probably the best player in the women's NBA. She had a bump at the top, this perturbation to her body, which led to her trunk coming lateral to the knee joint, which led to the collapse of the hip and the knee and the ACL rupture. And she never quite recovered from that. So if we're looking from the body habitus, what you see is this lower extremity valgus with knee abduction. And what I mean by that is distal tibial abduction. Her tibia, distal tibia and foot are moving away from the body. Her knee and hip are collapsing in. This happens with the knee in low flexion and with the foot on a single leg, flat and rotated with the center mass away from the foot base. Now, if you focus in on the knee joint, and let's say this is my tibia and this is my fibula, what you get is this combination of three rotations. You get this distal tibial abduction, you get anterior translation, especially of the lateral plateau, combined with internal rotation, and the ligament ruptures. So anything we can do to prevent those motions is going to reduce risk. And we know that we can reduce risk. This is a paper that I published with Kate Webster just about a year and a half ago, where we showed that you could reduce by 2/3 the risk of non-contact ACL injuries in women. And this has gotten a lot of attention. It had a Sunday article in the New York Times. And we followed that study up with several studies. So this is the current clinical practice guideline for the sports physical therapy group of the American Physical Therapy Association. This is a really good reference because it incorporates not only several programs in here, it also has attached videos of ACL reduction techniques. Now, again, getting back to the injury mechanism, what we've used is multiple converging research approaches. So we look at a lot of data points, in silico data points, in vitro, so cadaveric modeling, but also actual athlete in the lab using 3D motion analysis. And we take these in vivo, in vitro, and in silico approaches, and we bring them together, and we throw all the data up against the wall, and we look and see where the points intersect. And we know those are the valid and real and trustworthy data points. So again, getting back to this mechanism, what we know is that it's a combination of loads. Sport, life happens in all three planes of motion, and so do these injuries. They combine this knee abduction, this knee, what's called valgus motion, or CAM, and combined with anterior translation and internal rotation happening simultaneously, and you get a rupture. Now, we started modeling this back in the 1980s, and basically what we showed is it takes about 2,000 newtons of force, or about 500 pounds, to break a ligament like the ACL apart. And then we started studying this in robotic manipulations of actual movements of landing. And what we saw was that relative to the intact knee, these ACL injury mechanisms are quite responsive to this combination of loads: knee abduction, anterior translation, internal rotation. As you can see, when all loads are applied combined, you get much higher strain in the ACL. So the problem with some of these attempts at doing this is, for example, the robotic concept, it's slow, as you saw. So what we wanted to do was this in real time and see what kind of loads and how fast this actually occurred. So we started building injury simulators in the laboratory. This was the last updated version, where we actually simulate in a cadaveric knee the loads that it requires to rupture the ACL. And then we have our surgeon come and do an exam prior to the testing and then afterwards. And what he sees are ACL ruptures with our simulators that look exactly like what he sees in his arthroscope during surgery. What we see is we get femoral avulsions, complete mid-substance tears, and partial mid-substance tears. And what we did is we looked at our current impactor, compared it to the literature, which is in gray, and compared to an earlier version of the simulator. And what we show is we get truly clinical presentation of ACL injuries. And so our validity is established. We get the exact same patterns you see in the clinic. We also see sex difference in ligament strain. So if you normalize per cross-sectional area, females have increased peak strain. They have, it happens more rapidly, and this doesn't happen in the ACL as a control. If you look at sex differences in forces, what males tend to be is more sagittally plane oriented. They work in more flexion extension around the knee joint, whereas females tend to get more of this varus valgus motion, which leads to higher strains and higher risk of ACL. What we showed, what's been 15 years ago now, is you can actually screen and predict for injury risk, or at least you can look at risk stratification. And what we showed is we had pretty reasonable 73% sensitivity, 78% specificity for prediction of those who are going to go on to an ACL tear. They had about 8 degrees more abduction and about 10 degrees less flexion. And if you look at just that knee abduction angle at initial contact, what you'll see is the spread there, those X's show significant increase in risk. Those are the ones that go on to ACL tears. So not only can we risk stratify those that are going on, what we see is somewhere between half and 2/3 of those scatter points are at relatively high risk. And then if we add a laxity measure like knee recurvatum, so what you're doing to hold the knee joint together is using neuromotor control, but also the passive restraints around the joint. So if you have that combination of really a lax joint and a lot of valgus load on the joint, what we can predict with is an injury risk ratio of 15 to 23 times greater in that combined population. Importantly, the ACL is not just a passive ligament. It's richly innervated. It has all 4 types of mechanoreceptors. After the ACL tears, the question is the sensor gone? Does this sensor ever return? And what do you as rehabilitation professionals do to bring that sensation back? And I would argue what you're developing is extra articular controllers and sensors of that joint, because the tissue they put in there to religamentize is probably not reinnervated, and even if it is, it's not highly calibrated as required to sense that joint properly in three-dimensional space. So the ACL reconstruction is not a sensor. It provides joint stability. It prevents excessive, especially anterior translation. It doesn't do so well on internal translation or valgus, and it may prevent further articular damage, but it's not a good sensor. This is a series of dynamical systems approach studies that we did in the laboratory, much as Natalia and the group there in Belo Horizonte do. And basically what we showed is, if you look at uninjured controls, we asked these subjects to bring in matched players, same sex, same general weight and height. They usually were the same position players. And this is what happens in that sway when you go from 20 hertz per second sway to where she was swaying, 0.65. What you get is 0 degrees out of rotation to exactly 180 degrees opposite rotations of the lower extremity. What you see here, and you get more variability, what you see here in someone who has their ACL reconstructed, when the speed increases of that sway, they actually start to lock down the joint and decrease the degrees of freedom. And then someone who's going to go on to a second ACL injury has exactly the opposite pattern. So the slow speed is difficult for them. It's high variability, and their hip and ankle, for example, are 180 degrees out of phase with one another in their motion. And then when it goes faster, they don't sense the joint well, so they lock down the degrees of freedom. So this is a cross-recurrence analysis approach where we showed a control subject, their phasing of the lower extremity joints is very linear and very continuous, as in on the left. And then someone who has an ACL reconstruction doesn't sense that joint as well, and that continuity and linearity start to break down. And then someone who prospectively and subsequently goes on to a second ACL tear has complete breakdown of that phasing of the joints and the association of those joints. And that leads to this problem. So once an ACL is torn and reconstructed, what you have is this ACL sensory loss. And our working hypothesis is that leads to this pain and arthrogenic muscle inhibition, chronic swelling and inflammation, which leads to knee muscle atrophy and changes in the joint. And what you're actually measuring is that downstream knee joint dysfunction that you see in these altered movement biomechanics, as I'm showing you. There's other problems with bone health. For example, you get bone bruises. When you get this kind of rotation and translation, what that leads to is bone bruises at the high impact point of the posterior lateral tibial plateau and the anterior lateral femoral condyle. And these MRIs show evidence of that, and they take quite some time to heal. Scott Dye's work with bone scans show that this takes 18 to 24 months to heal. You also have muscle strength problems, decreases, and atrophy. You get huge, as you all know, atrophy in the quadriceps that takes quite a while to rebound and is very large in the range of 80%. And then you get sustained hamstrings deficits, especially if you take the hamstrings and what you see is ham quad ratios that are even decreased and increased anterior tibial shear stress. So what we proposed early on is, if you look at sensory function, proprioception, kinesthesia, movement biomechanics, bone health, knee muscle strength, psychology, none of these return properly until about 2 years. So waiting by time is not the answer. So what we did is we developed this proposed return to sport risk factor model, where we said you should use at most 5 factors like proprioception, neuromotor control, ligamentization, knee health, psychological factors to build and assess and test until you return an athlete. And this is what we call our 5 facts max model, picking out 5 factors, because if you have a good predictor, it has to have at least an R value of 0.4, which means it accounts for 20% of the variation. So if a good predictor accounts for at least 20%, you don't need more than 5 predictors. And this is an infographic that was put together over that 5 facts max model when we published it. So what we've gone on to since the primary work is we've gone into secondary prevention or secondary risk reduction. And basically what we did is looked at residual strength deficits that limited athletes' ability to return to sport. What we see is these asymmetrical loading patterns. What you see is when you land on a force plate and take off on a force plate, or whether you walk across it, you get 2 humps. You get the first hump is the ground hitting you, and that's I call the risk hump. And the second hump of this 2-humped camel, I call your power or control hump. That's you generating force off the floor. What you get is this asymmetry between the two. It doesn't go down on the ACL reconstructed side, but that landing force and that risk goes up on the contralateral side, which increases risk. And this was shown in this paper here, these limb asymmetries we see. So you get this loss of neuromotor control with these injuries. This athlete has dislocated his knee, lost all his passive structures, and it's a really interesting biomechanical study which shows that only a slight increase in the movement of his center of mass increases the lever arm of that force and increases torque at the knee. So it's important to point out, once this happens, the problem is big, especially in young active athletes. We first published a series of studies where we showed that the risk was about a quarter within 1 year and about a third at 2 years. And we were worried a bit about publishing this until Kate Webster and Julian Feller from Melbourne, Australia, showed their follow-up studies. They showed the exact same numbers. And so did Leo Pincheski, based out of Sydney. These people are people who do unbelievable numbers of ACL injuries. They came up with the same number we did, about a risk of about a third of a second ACL tear. Now, we started collaborating at that time with the group out of Melbourne, Kate and Julian, because ACLs are produced in Aussie rules football or footy at a very high rate. The incidence of ACL injury is the highest anywhere in the world in Australia, primarily because of footy. And what you do is you get this massive number of ACL injuries. And what you get, because as I showed you with that Rebecca Lobo video, you're getting this repeated incidents. And if you look at women's Aussie rules football, which only became a pro sport a few years ago, we started looking at that. So men have a risk of about 0.8 per thousand, which is very high. That's significantly higher than, say, women's college basketball and football in the US. But if you look at women in the ACL, in the AFL, their risk is significantly higher. So women's basketball and soccer incidence is about 0.3 to 0.4. AFL men is at least double that. And AFL women are at least 6 to 8 times greater. So this is a big problem, but it also leads into studies in pro athletes. And this is a series of studies we did of videos looking at second injuries, looking at timing of when they happen. And what you see here is they most often happen early, not late, which gets at the question of, is this a fatigue issue? And it probably is not. When injuries occur, it's not significant, but they're at least as likely, if not more likely, to happen in the first quarter as they are in the last quarter. So this is another consensus paper, and if you look at this consensus paper and training to reduce primary and secondary ACL injuries, you don't see fatigue one time. So fatigue is not what causes ACL injuries. And if you look at, this is the good news, if you work with athletes and you do proper risk reduction techniques, you can reduce the risk by 2/3 of non-contact ACL injuries. We published a study 20 years ago where we showed risk reduction of all knee and ACL injuries by half and risk reduction of non-contact in female athletes by 2/3. When we did this meta-analysis of meta-analysis, all the meta-analyses in the literature, we had the exact same problem. Now, fatigue may not be an issue, but the brain certainly is involved, because once you have an ACL tear, or I'm sorry, once you have a concussion, your risk of an ACL tear or any general knee injury is significantly increased. You've altered your neuromotor system. So again, if you look at, you take it down to ACLs, what you see is a significant high, about a 2/3 increased risk of an ACL tear after a concussion. So there aren't fatigue effects of ACL injury. So if you look at this was a meta-analysis we did with Tim Doyle in Sydney, and basically we showed whether you look at the first versus the second half, the first versus the second quarter, the first versus the fourth quarter, fatigue is not an issue. But people say, well, if you do these fatigue protocols, you're going to change the angles, you're going to get more valgus. That's not true. There's no significant change. This is a meta-analysis of the literature. There's no fatigue, there's no consistent fatigue effect on EMG muscle activity either. If you look at the effect of fatigue, it's actually on force. And what it does consistently is decrease force, and force is required to tear ligaments. So a fatigued athlete may actually be less likely to tear their ACL. So in this series of studies, we did large prospective cohort studies, and we showed those athletes that actively internally rotate their hip and abduct their hip and knee have significantly greater risk of a second ACL. This is the net impulse, hip internal net impulse moment. The red graph is those that go on to an ACL tear. The black graph is those that don't. And what you'll see is the hips are internally rotating and the knees are collapsing in those that go on to a second subsequent ACL injury. And we came up with a risk prediction curve where we showed that just that net hip internal rotation impulse could predict risk of an ACL tear with 92% sensitivity and 88% specificity. This is Baron Davis tearing his ACL graft. So let's look at his motion. What he's doing is stepping out, lands flat-footed, and then look at the net hip internal rotation impulse that he displays. Net, see that? Hip internally rotates, knee abducts, hip adducts, and he tears his graft the second time. So outcomes after ACL, because of loss of this proprioception, loss of neuromotor control, remain questionable and challenging. There's varied success to return to sport. There's these abnormal neuromuscular strategy, this stiffening strategy, frontal plane changes in the knee, lower extremity asymmetries, and high incidence and prevalence of OA, 50% plus. And then the second injury risk is really high, somewhere between 1/4 and 1/3. So what we need to do next is look at current rehabilitation guidelines and then use targeted secondary training, targeted to these net hip impulse moments, this knee adduction motion, this asymmetry in relative knee moments at initial contact between one side and another, very different relative quad ham activations, especially if hamstring grafts are used, and decreased postural stability, this stiffening strategy. And our proposed training guidelines are to address the trunk and lower extremity 3D motion that's observable, that symptom, use independent and combined exercise, use a very phase-based progression, not time-based progression, and then progressively add difficulty, degrees of freedom, volume, speed, perturbations, and total control before progression. So look at ligament dominance problems and correct them, quadriceps dominance issues, turn on the posterior chain, leg dominance, create side-to-side balance and control, and trunk dominance, create better core neuromotor control and move toward technique perfection before that athlete is allowed back on the court or on the field. So 4 phases: dynamic stabilization, functional strength and power, symmetry, and then core strengthening. Again, what we're proposing is this ACL sensory loss leads to pain, swelling, muscular atrophy, and weakness, knee dysfunction. That leads to both second ACL injury and post-traumatic OA. So if you're going to use timing alone, if you're not going to use objective progression criteria, then you better wait out 2 years, because that's when everything comes back to baseline. Focus in on a maximum of 5 factors. Focus in on those factors that are important, 4 important phases. And then also, if you look at the genetics of this is Carmen and Katie's pedigree here. This is Carmen and Katie here, these identical twin girls. Now, what we did is we had a fun family picnic where we collected blood on all 34 living relatives. So we have genotype this whole family tree. And if you go up 1 generation, this is their father. And what you see here is Jim has 3, there's 3 identical triplet brothers. All 3 had bilateral ACL tears. And interestingly, one of the uncles recently died of a myocardial infarction. So where we have to go with this is look at the neuromuscular imbalances in athletes screen. We don't look for this athlete who uses his knees like hinges on stiff muscular springs to absorb and dissipate force, but we look at this athlete. So again, springs on stiff muscular springs absorbing force, ball and socket joint where the force goes directly to the knee and the ACL. And then what we have to do next is focus on this athlete. If she's ligament dominant, we're going to teach her frontal plane control of her knee and hip. If she's quadriceps dominant on the bottom, we're going to turn on her posterior chain. If she's leg dominant or trunk dominant, we're going to start proximally, work distally, and create symmetric control side to side based on the trunk, so that when the trunk gets perturbed, hopefully that injury risk is reduced significantly. I want to thank you for your time. I want to thank a whole lot of people who've worked on these studies with me for the last 25 years, and I really appreciate it so very much. Obrigado.
Thank you, Tim. Thank you so much. It was an impressive presentation with a lot of information, so I'll try to summarize. I'll do my best. And if I have some doubts, I will